Peripheral ultrasound case diaries, case number 5, a case of finger drop. 55 male from village presented with complaints of progressive weakness in left hand finger extension since last 1 to 1.5 years, for which he visited multiple clinical practitioners in his village as well as from nearby towns, but there was no relief. He gave no history of trauma. His left hand finger extensors were weak with power of 2 by 5. Left wrist extension was however normal and there was no sensory deficit. So based on this clinical history and examination findings, it's clear that we are dealing with some pathology affecting posterior interosseous nerve, as it is the motor nerve of extensor compartment of forearm. It provides innervation to 4 superficial extensors and 5 deep extensors of forearm. It gives no sensory supply except for few sensory branches that innervate dorsal wrist joint capsule. EMG-NCV was done, which also echoed the same findings. So, based on clinical history and EMG-NCV findings, we know that we are dealing with a case of posterior interosseous neuropathy. But what is the cause for it? In order to decide the treatment, we need to know the underlying cause. Is it an entrapment neuropathy, which is by far the most common cause for pin neuropathy? And in fact, this patient was being treated as a case of pin entrapment neuropathy, but he had no relief. Is it a traumatic neuropathy, which is another important cause for pin neuropathy? However, he gave no history of trauma. Is it an infective neuropathy? Is it an inflammatory neuropathy? Or is there any neoplastic condition which is responsible for pin neuropathy? So, in order to decide the underlying cause, we need to do morphological imaging. And this patient was referred for high resolution ultrasonography of left forearm to trace the posterior interosseous nerve. So let's do the ultrasound. This is the posterior interosseous nerve. This is the superficial head of supinator, and that is the deep head of supinator. As I am scanning distally, what we can see, pin is ending into this large heterogeneous complex solid mass lesion that is located in the extensor compartment of left forearm between superficial and deep extensors. As I am rotating my probe along the long axis of this lesion, we can see this lesion is proximally in continuity with posterior interosseous nerve. This is the posterior interosseous nerve lying between the superficial and deep heads of supinator. This is the axial image of left proximal forearm. We can see this is radius, this is ulna, and this is the big mass lesion that is located deep to the extensor carpi radialis brevis muscle belly and adjacent to the extensor digitorum communis and supinator muscle bellies. If we put on the color Doppler, we can see this mass is showing moderate internal vascularity. This is the panoramic ultrasound image which nicely demonstrates the entire extent of this mass lesion. This is the superior end and this is the inferior end. We can see this is a posterior interosseous nerve which is seen entering into this mass, which is also called as nerve entry sign, and this is a posterior interosseous nerve exiting from the mass, which is called as nerve exit sign. This is the entire extent of this mass, and so the diagnosis is peripheral nerve sheath tumor arising from posterior interosseous nerve, and this was in fact proven to be schwannoma on histopathology. Another important thing that one should look for in cases of neuropathy is the status of end muscles. So this is the axial image of left forearm extensor compartment, and we can see there is significant reduced bulk with fatty infiltration involving the deep extensors of forearm. Superficial extensors are also showing some patchy areas of fatty infiltration. This is the left forearm flexor compartment muscles axial image, and we can see well maintained bulk of flexor compartment muscles with maintained ecotexture. So, with the help of high-resolution peripheral ultrasound, we can diagnose various peripheral nerve pathologies, and ultrasound is a very cost-effective imaging modality, but it also gives a concrete diagnostic information. It is the only imaging modality which allows dynamic real-time assessment. Low cost doesn't mean that we are doing a compromise. In fact, ultrasound has got higher resolution than MRI. Ultrasound allows vascularity assessment with the help of color Doppler without need for IV contrast. Very importantly, we can scan entire nerve in one go, whereas if we want to scan the entire nerve with MRI, then we need to use multiple coils and it's going to take a very long time. There is no contraindication for ultrasound and it can be safely done in claustrophobics, in pediatric patients, patients with pacemakers and metallic hardware. So this case highlights how exquisitely high-resolution ultrasound can diagnose various peripheral nerve pathologies. Though most common cause for finger drop is pin entrapment neuropathy, morphological imaging, particularly high-resolution ultrasound, is very essential to exactly pinpoint the underlying cause. Thanks for watching.